All right, I guess we'll go ahead and get started. So I think we'll be covering obstructive sleep apnea followed by rhinology. So we'll start with obstructive sleep apnea. We have quite a bit to cover in this first hour of lecture. So if you guys have questions or things along the way, just feel free to send those to the Q&A box, and we'll probably try to save all questions for the end. All right, so this is kind of an outline of the objectives of the talk. We're going to start by discussing a little bit about physiology of sleep apnea, its consequences, the symptoms and workup, and then we'll kind of go through a little bit of medical and surgical treatment options. So when we think about sleep apnea, these are the categories. It's not meant to necessarily be all encompassing or totally exhaustive, but essentially you think about sleep apnea broken down into different sleep disorders broken down into different categories. There's sleep-related breathing disorders, which includes patients that have obstructive sleep apnea, where we'll be spending most of our time today talking about, but also insomnia, hypersomnias of central origin. We'll discuss a little bit of that, circadian rhythm disorders, parasomnias, and then sleep-related movement disorders. And there's different kinds of things that can fall into these categories. And it's important to kind of think about sleep apnea and how it exists on sort of a spectrum. This can go from mild up to severe, snoring up to UARS, and we'll talk about all the different definitions and why that's important. But most of the time we'll be just focusing on obstructive sleep apnea for the purposes of what's important for our purposes in otolaryngology, but also what's important for you guys to know. And parasomnias, just to kind of talk about, are kind of any kind of undesirable movement or some kind of subjective phenomenon that can occur during sleep and can result in an EEG change. Sometimes that can occur while waking up or just during sleep itself. For example, these phenomenon can, think about things with different kind of autonomic symptoms that you may have, problems with sleepwalking or night terrors, things like that can fall into the category of parasomnias. Additionally, there are certain types of parasomnias that can result in sleep hallucinations. One category or one definition that you should be familiar with is a hypnagogic, which happens just prior to falling asleep, and then hypnopompic, which usually happens right as you arise out of REM sleep, just before wakefulness. And anything that we kind of go through in the slides that has either bolded or sort of color-coded are kind of important definitions and terms that you should just commit to memory. So the first definition that we'll cover is what is an obstructive apneic event. And that's defined as cessation of airflow for at least 10 seconds with an effort to breathe. An essential apneic event carries the same definition, but without that effort. So really that's important for you to commit to memory, understand what that means, especially as we interpret PSGs in the data that we get. So there's several different definitions of hypopnea, but kind of what's recommended is the CMS definition. The American Academy of Sleep Medicine also has its own definition, but I would recommend the CMS definition, which is defined as a 30% reduction in airflow for at least 10 seconds with a 4% oxygen desaturation. And that's sort of the one that you should commit to memory. That a hypopnea is just that reduction with a desaturation, but again, it's not a total flat EEG line that we're seeing without any cessation or complete cessation of airflow. There's a reduction of airflow, but not complete cessation. And that's what defines a hypopneic event. When you look at sort of the questions that you may encounter, or when you're looking at sleep studies, it's kind of important to look at what the question is asking. Are they asking for AHI or are they asking for RDIs? So AHI would be your apnea-hypopnea index, which is basically based off of those two definitions that we just covered, whereas an RDI is going to look more at things like the respiratory effort-related arousals, things that are more helpful to define other conditions that are sleep disorder breathing conditions such as upper airway resistance syndrome, but not necessarily true obstructive sleep apnea. So a respiratory effort-related arousal, or RERA, is when you have increasing respiratory efforts that result in an arousal, and that does not meet the criteria for apnea or hypopnea. And an arousal can be any kind of abrupt change in the EEG, but that has to occur for at least 3 seconds or longer. So we mentioned parasomnias, restless leg disorders, things like that can have EEG changes, but again, not necessarily having any criteria that meets apneic or a hypopneic event. And that's especially important when we look at patients that have UARS, which we'll discuss in an upcoming slide. So here's the definition between, or the differentiation between AHI and RDI. So again, the apnea-hypopnea index is calculated per hour of sleep, and that's the number of apneas plus the hypopneas. And the respiratory disturbance index, which is the RDI, is when you take the AHI and you add in the RERAs, the respiratory effort-related arousals. So again, that's when you have those arousals of the EEG, but they do not meet the criteria for either an apneic or a hypopneic event. So these are kind of self-explanatory and sort of intuitive. Sleep latency is simply the time to fall asleep. And then sleep efficiency is your total sleep time divided by the total recording time. So normal sleep latency should be, for most of us, about 10 to 15 minutes. And that's kind of, how long it takes us to fall asleep. But that's not how long it takes us to get into REM sleep, which we'll discuss in a later slide. But the idea is that's normal sleep latency. And that'll be important when we look at patients that have central hypersomnic disorders like narcolepsy or hypersomnolence. And sleep efficiency essentially tells you how good the recording or how good the data was. So for, most times we want to try to get a sleep efficiency of around 75%. But, for things like pediatrics or kids, sometimes we'll just tolerate a shorter sleep efficiency. Like maybe they can only tolerate 3 to 4 hour sleep test, especially when it's done in the lab. For kids, that can be a lot harder. So we can tolerate that, but for generally to get an adequate PSG reading and to get good data, you're looking for about 75% sleep efficiency. So again, this is kind of an important slide to sort of commit to memory and just sort of understand the buzzwords that are associated with certain stages of sleep. One stage that's not really listed here is the stage that's kind of the pre-stage 1 or pre-sleep stage, which is called relaxed wakefulness. And that's when you kind of are starting to sort of fall asleep, or you're starting to get very relaxed. That's associated with alpha waves, maybe after a long day, just kind of right before you hit your head on the pillow, but before you fall into that stage 1 sleep, you have alpha waves, which can be picked up, and that's known as relaxed wakefulness. Then we go into stage 1, which is associated with theta waves, stage 2, which is associated with sleep spindles and K complex, stage 3, delta or slow wave sleep, and then we drop into REM sleep. So one thing I'm going to do is I'm going to send a primer out for you guys to look at, and the primer is actually a really good kind of a short booklet that tells you how to go through a sleep study. It tells you how to read an epic, which is usually about 10 seconds of a PSG. It shows some differentiations between the EMG, the EEG, how to differentiate a hypopneic and an apneic event. So I think that'll be important. So I'll send that out to the Osler staff, in fact, for them to send that out to you later on so you guys can review that at your leisure. But basically that will kind of go through and show you which of these stages you're looking at and how you correspond that to a PSG. Additionally, what's really important to realize is that the bulk of our sleep is really not spent in REM. The bulk of our sleep is actually spent in these first 3 stages here. And a normal sleep cycle is about 90 to 120 minutes. But it takes us about 70 or 90 minutes, because most of our time is really spent in those first 3 stages to get into REM sleep. And when we have a REM sleep cycle of this total night that we're in REM, the total number of hours we're sleeping, if you're looking at 7 or 8 hours, only about 20-25% of that time is spent in REM. But REM is the most important stage of sleep when it comes to discussing obstructive sleep apneic events or obstructive events. It's also the most restful part of our sleep, where we have to really kind of have some of these homeostatic regulations, these mechanisms. So, but we only spend a small percentage of our entire sleep cycle in REM. So it takes about 79 minutes to get to REM, and if you're looking at like an 8-hour sleep cycle or sleep per night, you're looking at getting maybe about 4 to 5 cycles of REM. And I mentioned that kind of ideal that one sleep cycle is about 90 to 120 minutes. That's actually also the ideal nap time. So the next time you guys want to take a nap, or if you're post call or just wanting to rest, I encourage you to let your attendings know, I'm going to take a nap. I need at least 90 minutes so I can hit 1 REM cycle, and I'll be much more relaxed and ready to go for the rest of the day. So, when we talk about snoring, initially, we used to look at just pharyngeal vibration, tonsillar pillars, and it's important to look at those structures because historically the uvula was given a lot of attention when it came to snoring. And you'll see that when you see patients, you have them open their mouth, you can kind of see the uvula might be elongated, it might be edematous, it might look a little bit like a punching bag, and you kind of think, okay, well, the uvula must be the main driver of snoring. But in fact, it's not really just the main driver of snoring. It has to do with the redundancy of the palate, pharyngeal vibration, the size of the tonsillar pillars, and also, it also has a lot to do with our sleep hygiene. So one of the things is, about 30% of our patients, if you're going to screen for sleep apnea and sleep disorders in your practice, have poor sleep hygiene, and that can actually cause a lot of issues with snoring. That may be because they smoke. That can cause pharyngeal edema. It can cause some reflux. They may take sedatives or even a glass of alcohol before they sleep at night. That can reduce pharyngeal tone. This can result in snoring and worsen apneic events. Also, snoring is more common in males versus females, and more common in supine sleep as well. So my point is, when you think about it, and you see the patient in your clinic and you're doing a good oropharyngeal exam, I encourage you not just to focus on the uvula, but follow that uvula up, look at the redundancy of the soft palate, look at the tonsillar pillars, look at those areas to see if there's other things that may predispose them to snoring. Because historically, when we looked at snoroplasty and pillar implants, the idea was we're trying to reduce that pharyngeal vibration and cause some stiffness in the submucosal planes and thereby reduce their snoring. But as we've come to understand more of the uvular functions, that's also been kind of why we've gone away with certain procedures like uvulectomies. And we'll talk about that a little bit more as we get onto the other surgical management of sleep apnea. Okay, so early on, I kind of mentioned UARS, or upper airway resistance syndrome. And this is when you have those increasing respiratory efforts that result in EEG arousal. But again, this is driven by RDIs and not purely based on the AHIs. In fact, these are patients where the AHI or the sleep study might actually look normal. You might have an AHI of less than 5, or even a normal sleep study, which is 1 to 5, or have no really apneic or hypopneic events, but their RDI is elevated. So this is something that, when you look at a home sleep study, for example, you're not going to be able to differentiate someone that might have upper airway resistance syndrome from someone who has obstructive sleep apnea, because the home tests aren't going to calculate the RDI because they don't take into account the hypopneas or the apneas. So in these kinds of patients, these are patients where you kind of have to have a little bit more of a kind of a clinical suspicion. They may not have the classic obstructive risk factors like thicker necks or obesity. They may actually be more slender. The incidence is equal in men and women, and also equal between obese and slender individuals. So these are patients where you kind of think, well, they don't quite have all those classic features. It might be UARS. And that's, again, we got to look at those RERAs, the respiratory effort related arousal syndromes, knowing that this is more common in the younger populations and more healthy people without necessarily the long-term consequences like AFib or things like that. And this is where you really want to differentiate snoring from UARS. And that's kind of, like I mentioned, it's kind of a continuum. So snoring, mild, UARS, mild OSA, all the way up to severe OSA. And that's in contrast to our classic kind of OSA risk factors, which we're probably mostly familiar with. These are patients that are, as we get older, the pharyngeal dilators have less tones. They tend to relax more. So as we get older, we've seen higher incidence of sleep apnea. Obesity, commonly associated with a BMI greater than 35. In children and pediatric populations, congenital abnormality, Treacher-Collins, Pierre-Robin's, Down syndrome. Certain ethnicity or ethnic groups can have a higher risk of sleep apnea. It can also be due to mandibular displacement. If they're more retrognathic, they're more likely to have obstructive sleep apnea. And the genetics, it's a little bit controversial. The genetic, if you look at the literature, people with sleep apnea, there is potentially up to 30% higher risk of having sleep apnea if you have a first-degree relative with that condition. But the literature is not totally clear on genetics. But when most people come in and they may ask, if I have it, do my kids have it? The answer is there probably is a genetic component to it, but we don't know entirely how strong that connection might be.